Shoulder pain. You see it on your schedule every single day, right? But as common as it is, figuring out what's actually going on can be, well, a real puzzle. So, how do you cut through all that confusion? In this explainer, we're going to build a solid step-by-step framework so you can walk into that room and tackle your next case of shoulder pain with total confidence. So, there it is, on the schedule. Chief complaint, shoulder pain. But where do you even begin? Is it the rotator cuff? Is it referred pain from the neck? Something else entirely? This is a moment every single one of us faces, and it's exactly why having a reliable system is an absolute game changer. All right, the very first question you need to answer, before you even start thinking about specific diagnoses, is a really fundamental one. Is this pain actually coming from the shoulder joint itself? This right here, this is probably the most important fork in the road of your entire workup. It's your first big decision. If you can make the patient's pain show up just by moving their shoulder around, you're almost certainly dealing with an intrinsic problem. But if shoulder movements are totally fine and it's turning their neck that triggers it, or if the pain shoots down past the elbow, you got to start thinking extrinsic causes, like a pinched nerve in the neck. Nailing this first step doesn't just save you time, it literally stops you from chasing the wrong diagnosis from the get-go. Okay, so you've determined the pain is probably coming from the shoulder. Awesome. Now it's time to put on your detective hat. All the clues you need are right there in the patient's story and in what you find on your physical exam. Every single one of these questions is a critical piece of the puzzle. Was there a sudden fall, or is this more of a slow burn from years of overhead work? Does the pain wake them up at night? That is a huge clue for rotator cuff problems. And here's a really subtle but vital point. Are they truly weak, or are they just afraid to move because it hurts? The answer to that is crucial when you're trying to figure out if there's a full-on tear. Look, there are dozens of special tests for the shoulder, but honestly, these three are your workhorses. Now, the real key here isn't to rely on just one. The diagnostic power comes from putting them together. For example, if you get a positive painful arc test and you find weakness when they try to rotate their arm outward, your confidence in diagnosing a rotator cuff tear just went way, way up. So let's walk through the drop arm test because it's a great one. First, you lift the patient's arm all the way up for them so their muscles are relaxed. Then you tell them, okay, now you take over and lower it back down, nice and slow. If they can't control it and that arm just suddenly drops, that's your classic positive sign. It's highly suggestive of a complete tear of the supraspinatus tendon. Super simple, but a really powerful test. All right, you've gathered your clues from the history and physical exam. Now it's time to put it all together and build a solid differential diagnosis, starting with the most common culprits you're going to see. By far, the number one cause of shoulder pain you'll encounter is rotator cuff disease. It's really important to remember this isn't just one thing, right? It's an umbrella term, a whole spectrum of conditions. It could be simple inflammation of the tendons, or what we call tendinopathy, all the way to partial or even full-thickness tears. And this right here, this is the classic story you're going to hear. Listen for it. Patients almost never point to the very top of their shoulder. They'll point to the side of their upper arm, right where the deltoid muscle inserts. They'll say it hurts to reach up into a high cabinet, or famously that they just can't sleep on that side anymore. And if they mention weakness on top of that, your suspicion for a tear should be really high. Next up is adhesive capsulitis, better known as frozen shoulder. Now, this one can be tricky because on the surface, it can look a lot like rotator cuff disease. You get that similar pain on the front and side of the shoulder, and it's often worse at night. But there is one dead giveaway that sets it apart. This quote is everything. It is the absolute key. See, with rotator cuff pain, a patient might not be able to actively lift their own arm because of pain or weakness, but you can still move it for them passively. With a true frozen shoulder, that joint is genuinely stuck. Neither you nor the patient can get that full range of motion. If you remember one thing to tell these two apart, let it be this. This brings us to the million-dollar question, the one I know every trainee has. Okay, I think I know what's going on. Should I order an X-ray, an ultrasound, an MRI? When do we order the scan? So when is it really necessary? Well, the answer might actually surprise you. For most cases of chronic shoulder pain that didn't come from a specific injury, the diagnosis is clinical. You often don't need imaging right away. So when do you pull that trigger? These are pretty much your main reasons. If there was a big fall or a serious injury, yeah, you need to image to rule out a fracture. If your exam is screaming acute, full-thickness tear in an active person, that's another good reason. Otherwise, it's totally reasonable to start with conservative therapy and only get a scan if you're still not sure what's going on, or if the patient isn't getting better after a few months and you're starting to think about surgery. And hey, here's a fantastic clinical pearl to stick in your back pocket. A lot of us default to ordering an MRI for shoulder pain, but the evidence is clear. For rotator cuff problems, a good ultrasound, done by someone experienced, is just as accurate. Plus, it's cheaper, it's faster, and you don't have to worry about claustrophobia. So next time you're thinking about imaging for a suspected tear, seriously consider ultrasound first. It's a great choice. So you've locked in your diagnosis. Now for the most important part. How do you actually help your patient get better? Well, for the vast majority of common shoulder issues, the answer always starts with a conservative, stepwise approach. Now, before we talk about what to do, let's cover a really critical point about what not to do. It feels so intuitive to put a painful shoulder in a sling, but this can actually backfire. Immobilizing the shoulder for too long is a major risk factor for developing, you guessed it, adhesive capsulitis, a frozen shoulder. The goal is gentle movement, not shutting it down completely. This slide basically gives you the playbook. Step 1, it all starts with education, explaining what's going on and modifying activities. But the absolute cornerstone, the most important part, is physical therapy. We're talking about strengthening the rotator cuff and all those important muscles around the shoulder blade. For pain, we climb the ladder. Start simple with acetaminophen, then maybe add NSAIDs. And injections, they can be a great tool to cool things down for a little while, giving you a window for PT to be effective, but we use them carefully. And that really brings us to our final and maybe the most important point. You can have the best treatment plan in the world, but it means nothing if the patient doesn't buy into it. Your ability to explain why conservative therapy works, to set realistic expectations, and to make them a partner in their own recovery, that's what truly leads to the best outcomes. So the question to leave you with is, how are you going to frame that conversation to empower your next patient on their road to recovery?